Good morning, good afternoon, evening, everyone. My name is Elisha Dungiorgio. I'm the President and CEO of the Global Health Council. I'm very pleased to welcome you to today's webinar on the Mexico City policy. We are very glad you could join us for this timely session designed to shed light on a policy that could soon have major implications for global health and development programs worldwide. As many of you know, the Mexico City policy, often referred to as the global gag rule, has been a central and frequently revisited aspect of US foreign policy on global health. With each change in the US presidential administration, this policy has been alternately implemented and rescinded. And now with the upcoming US election next week, there is renewed attention and concern that the policy might not only be reinstated, but expanded, affecting even more aspects of health and development delivery and funding streams. So today we have put together an expert panel who will discuss more about the Mexico City policy, its history, and the potential impact of its reinstatement and expansion, particularly in those regions and on those organizations heavily dependent on US aid. We also will discuss some strategies that NGOs are considering in the face of potential shifts in US policy. Before we get started, I'd love to introduce our panelists. We have Ibrahim Nsireko, who is the head of Advocacy Capacity Enhancement at Haki, based in Uganda. Haki is an African research and training institute that uses Afrocentric approaches to generate knowledge and enhance advocacy capacities in the areas of health, human rights, and sexual and reproductive health and rights. We also have with us Jane Cronin, who was the Deputy General Counsel at CARE, where she worked for 13 years and is currently providing some pro bono support to CARE on the Mexico City policy. Also joined by Dr. Jennifer Cates, who is the Senior Vice President and Director of the Global Health and HIV Policy Program at KFF, where she oversees policy analysis and research focused on the US government's role in global health and on global and domestic HIV epidemics. And lastly, Caitlin Horrigan, the Senior Director of Global Advocacy at Planned Parenthood Federation of America, where Caitlin drives PPFA's global advocacy agenda with Congress and the administration to protect and expand funding and policies that advance sexual and reproductive health and rights. So I'm going to get to our panel in just a minute, but just a few housekeeping notes. So we'll hear from all of our panelists before turning to any questions from the audience. You can place your question in the chat and it will be seen by the panelists. Unfortunately, we don't have simultaneous interpretation for this, but you can enable captions in the language of your choice by clicking on the captions button in the toolbar and then selecting the language you'd like to see. Okay, so with that, I will turn to our first speaker, Caitlin Horrigan, to give us a little bit of a refresher on some of the history of the Mexico City policy. Caitlin, over to you.
Thank you so much, Elisha, and hi, everyone. It's great to be here with my fellow panelists and everyone tuned in here. Planned Parenthood Global was really glad to co-host this timely and important conversation along with our friends at GHC, PAI, and UAP. I want to start out by saying first that the Mexico City policy, also known as the global gag rule, is not currently in effect. And I wanted to underscore that point because historically there's been a lot of confusion over the back and forth of this policy, and that's resulted in a huge chilling impact and often over-implementation in the field. So I want everyone tuned in online to know that no one has to comply with this policy right now. It was rescinded in January of 2021. And what we're sharing here today is, of course, to inform future planning and engagement. But as Elisha mentioned, of course, we're here today because that reality could change quickly. And that's because this is a policy that is enforced or removed through presidential action, often in the first day or week of a new administration. So as we look towards the US elections next week and the swearing in of a new president in late January, we know that this policy could shift quickly, and it's important to be prepared as a community. So let me break down a little bit about how we got here and what this policy is. It was first put into place in 1984 by the Reagan administration, and it was announced as part of the International Conference on Population Development in Mexico City, which is why you often hear the policy called the Mexico City policy. Advocates also refer to it as the global gag rule because of what the policy does. So when in place, this policy blocks non-US organizations from receiving certain types of US foreign aid if they provide, counsel, refer, or advocate for abortion with their own private non-US resources. This is separate from and in addition to another law called the Helms Amendment, which bans the use of US foreign aid for abortion as a method of family planning. So after the Mexico City policy was first put into place, both Planned Parenthood Federation of America and DKT did try to challenge the policy in court, but unfortunately were unsuccessful. And since then, the policy has been enforced by every Republican administration and rescinded by every Democratic administration. For 40 years, the policy has thus changed every time there's a change in party control of the presidency. And so while the policy is put in place or removed by the president, it's enforced through grant agreements, meaning when you decide to accept US funds, you have to agree to the conditions of the policy. It's worth noting that if you are in the middle of implementing a US funded project when it comes into place, because we know many projects span multiple years and don't necessarily line up with US election cycles, the organization has to decide whether to comply with the conditions of the policy when you receive a new tranche of funding. I also wanted to share that there are some exceptions under the global gag rule. There's exceptions for abortions performed when the pregnancy is the result of rape or incest, or to deal with a life-endangering pregnancy. Post-abortion care is also allowed under the policy, and it's allowed to do something called passive referral, meaning if a person who is pregnant states that they've already decided to have a legal abortion and they specifically ask where they can obtain it, the healthcare provider may respond with a referral about where they can get that healthcare service. For most of the policy's 40-year history, it has applied to international family planning and reproductive health funds, which for the last 14 years have totaled around $575 million annually. However, under the Trump administration, it was significantly expanded and also rebranded as the Protecting Life and Global Health Assistance policy. The major expansion under the Trump administration was that for the first time, the policy was extended to apply to all global health funding, totaling around $9 billion annually. So this, for the first time, included things like maternal and child health funding, HIV funding, and more. They also moved to expand the way that the policy attached to funding from non-US sources, meaning that funding from, for example, a private foundation became newly gagged if it passed through an organization that was complying with the policy. And under previous versions, if a prime partner received funding from another donor, they did not have to pass along restrictions to any subgranted funds. And then the final expansion that I wanted to note that happened under the Trump administration was that they initiated a process to amend US regulations to allow the global gag rule to apply to contracts, not just grants and cooperative agreements. And at the time, contracts accounted for about 40% of US global health disbursements. So it was a very significant expansion. This change, however, required a longer formal process and an open public comment period, and it was never finalized in the first term. When in place, the global gag rule has applied to non-US, non-governmental organizations, although of course we'll hear about some ideas about where it could be expanded. And when we look to the US Congress, we actually have already seen attempts to make this policy permanent into law and also to expand it to new funding streams and partners. And we've even seen attempts to replicate it to different services. So swapping in something like gender affirming care for where we've traditionally seen abortion language. These attempts have been rejected so far, but we see them repeatedly offered both in standalone bills and in language in annual funding bills. But we also know that many members of Congress are also working to make the policy permanently repealed by supporting a bill called the Global Health Empowerment and Rights Act, or the Global HER Act for short. I thought I'd close on a more hopeful note, which is sometimes very hard to do on this topic. But I wanted to share that ending the policy permanently is supported by Americans. There's been multiple public opinion polling on the policy, including most recently one that was released in March of this year. And that poll found that more than 70% of respondents had major concerns about the global gag rule, especially its impact on healthcare outcomes worldwide. And that view cut across many major demographics, but was especially true among young people age 18 to 34 and people of color. There was also, by an overwhelming 36-point margin, Americans favored permanently ending the global gag rule. And that extended across party identity demographics. So let me pass it back to Elisha to transition to our next speaker to dig in a little bit more on the future look ahead. Thanks, Elisha.
Thanks so much, Caitlin, for that overview. Really appreciate the reminders of how we got here. Next, I'm going to ask Jen Cates to come onto the main screen here and talk a little bit more about potential implications moving forward.
We'll do that. Hi, everybody. Thanks for inviting me to be part of this panel and discussion. And Caitlin, of course, set up all the history and the basic facts. What I'm going to do is just share briefly the results of some research that my organization, KFF, has done on the policy and potential expansions of the policy, as well as implications and what literature tells us. So these are just research tools that you can all have access to. They're public on our website, kff.org. Starting with a literature review, we were interested in looking across the whole history of the policy from when it first was implemented a long time ago to the current era to say, what does the literature tell us about what the impacts, the known impacts or the potential impacts of the policy. And you can see here how we did the literature review, and there's a lot more detail online in the actual document itself. But taken together, when we looked across multiple studies, we found several impacts that are associated with the policy when the policy has been in effect. And different studies, different reports used a range of methodologies to come to these conclusions, but I'm just going to summarize them here. That these studies have found that when the policy has been in effect, it's associated with increased abortion rates, increased pregnancy, decreased contraceptive prevalence. There's been documentation of disruption in family planning and other services. And that is largely because networks had to be adjusted if certain organizations were choosing to comply with the policy and others weren't. And that has also led to gaps. The literature has documented gaps in service availability. Also, there's a really big push in global health to integrate services as much as possible. But when the policy has been in effect, it's been associated with reduced service integration. And as Caitlin already mentioned, that one of the other documented effects or associations with the policy is over implementing it. So either not knowing what the details were and doing more than was required, or because of concerns about what was okay or not. So some organizations just decide we're just going to be very careful here and not do any of these services, even if they're permitted. There's lots of confusion that's documented. The policy is hard to understand and it has changed over time. And led to loss of partnerships. And then, of course, the last one that the literature documents is increased administrative burden. So for an organization that is particularly newly having to grapple with this, it does require administrative changes to implement and be compliant. As I mentioned, this is on our website. We can send around links later for that, but there's a lot more detail in that analysis. So I want to change to next slide to another analysis that we did. Some of you may know that there has been a proposal put out by Project 2025, which is a coalition of multiple groups that are looking at if there's another Republican presidency, what would be recommendations that they would make across a range of domestic and international areas. And embedded in that document is a proposed expansion of the Mexico City policy. And what essentially it would do, and I'll walk through some of the findings that we had when we looked at this, is as Caitlin mentioned, it had already been expanded under the Trump administration to apply to virtually all of global health assistance. This proposal would apply it to virtually all of US foreign assistance, so a much wider range. We don't know if this would actually be what would happen with if Trump were to be reelected, but many think of this as a very likely scenario. So what it recommends is that the policy be applied not just to bilateral assistance, so that's money that the US government gives directly or on behalf of other countries, but for the first time applies to multilateral assistance. So the money that the US government gives to WHO or to the Global Fund or to Gavi or other international organizations. Not just health, but humanitarian assistance, economic support, and all the other sectors that the US supports through its development work. Also included in the proposal is not just to have it apply to foreign NGOs, but have it applied directly to US NGOs. So as Caitlin mentioned, the policy is always applied to foreign NGOs. A US NGO that was receiving money from the government had to ensure that their foreign NGO partners were in compliance, but the US NGO itself was not subject to the policy. The proposal would change that. And as Caitlin also mentioned, there had been an effort to try to apply the policy to contracts, and it's expected that would be pursued again with a longer time frame to get it done. And importantly, Caitlin mentioned this, members of Congress have introduced legislation that's very similar to this. So this is, while it's in a proposal for a potential Republican administration, I think it's just important to know that this is a conversation that's happening more broadly than at the administration level. So we analyzed what would this proposal mean in terms of funding and organizations and sectors. And to do so, we looked at obligations. So that's a technical term in US foreign aid, but it's when the policy applies, it applies to when it's obligated to an organization. And so we use 2022 as a proxy. And next slide, please. Oh, and this is just picking up on something that Caitlin was talking about, the change in the policy over time. We have a diagram in our report that shows you how it has been expanded over time in different ways and what this proposal would do that would expand it further. Next slide, please. So what we found in brief, that if this policy were to be expanded as proposed, it would apply to more than $50 billion in US foreign aid, and across more than 180 or almost 180 countries. That's very significantly greater amount of funding and countries than the prior Protecting Life and Global Health Assistance policy. Most of the funding, the majority, would be to multilateral organizations, which is important because multilaterals have not been subject to this before. And by sector, humanitarian assistance, funding for humanitarian assistance was the largest share. Again, another sector that has not had to be subject to this. We identified more than 2,400 non-USG prime recipients of foreign aid in 2022. Next, just some visuals. This is showing the type of recipient of that 51.5 billion in 2022. And you can see here that multilaterals make up the biggest amount of money, but also nonprofits and all the other sectors here, private sector, et cetera. Next slide. And just so you can see the sectors, health is 21%, but humanitarian assistance is 32%, and economic development is 23%. Just to note that, again, these are sectors that have not directly been subject to the policy in the same way. So it would present a new thing that many other organizations and sectors would have to grapple with. Next slide. And then the final slide I'll show is number of recipients. Health aid is primarily the main recipient in terms of number of recipients of foreign aid in 2022. But you can see here, economic development had almost as many recipients and all the way down. So just the report has a lot more detail in it and lots of tables that you can dive into and see who the top recipients were. But this is just to give an overview of the potential reach if this proposal were to be implemented. And it would, I think we might hear more about this from Jane and others. A lot of what is in the proposal is under the authority of a executive branch. So it is very much the case that a president could implement almost all of this without having to change law or seek other approval. Now, there may be some challenges to that, but it's just important to understand that there is a lot of executive authority to do these kinds of expansions. I'll leave it at that and look forward to your questions. Thank you.
Thank you so much, Jen. That was great. I'm just trying to unspotlight you. Okay. So you did a great job of talking high level about what some of the implications are, and we have two people on the panel who can speak to what that actually looks like. So I'd like to first turn to Jane. You were the Deputy General Counsel at CARE during the last Trump administration when it was expanded to be the Protecting Life and Global Health Assistance Act. So would love to hear, any lessons learned from that, what your experience was, and then we'll turn last to Ibrahim to talk about the experience of an in-country, recipient country civil society organization and what kind of impact this policy has on CSOs and on access to services in recipient countries. So Jane, let me turn it to you first, and then we'll have Ibrahim wrap us up before we go to Q&A.
Thanks, Elisha. And yeah, I just want to acknowledge Caitlin and Jen for what they've contributed, and what Kate's organization has provided over the years in research. We heavily relied on them when we were looking to figure out what in the world does this policy mean. So many thanks to the Kaiser Family Foundation for all the work that they have done and continue to do. It's been very helpful. So I'm going to talk about how, and as an INGO, I worked for CARE. I'm no longer with CARE, I've retired. I'm not speaking on behalf of CARE, but I'm speaking based on my experience of what I learned while I was doing this for CARE. And I've also now doing pro bono work on this topic for CARE. So I'm still aligned with them, but just not speaking on behalf of CARE. As the prior panelist said, when the 2017 rollout occurred, phase 1 was dealing with what it had in the past, family planning funding, and phase 2 was dealing with global health funding. The rollout was extremely confusing. It was ambiguous, it was vague. There was no training, no guidance. So that disconnect occurred not only with the INGOs and local NGOs, but also at the field office level with US NGOs, with US government agencies. And the rollout to the expansion to global health funding was particularly troubling because there's no one bucket of money that says global health funding. And when the US government would put out an RFA or request for application, the buckets of money were rarely identified. There's always mixed funding streams. So when you were applying for a grant, you didn't know if it was going to be subject to the Mexico City policy or the global gag rule, which is my preferred way to call it. So that added a lot of confusion. And then noncompliance was a big concern, which added to the chilling effect that Jen talked about, because of the noncompliance was significant. If someone was not compliant, they could lose the grant and have to return all the funding that they'd already spent in trying to achieve the accomplishments of the grant. So I even heard of local NGOs who were afraid to go to conferences where abortion was going to be spoken about for fear that would be considered a violation of the US government policy, which it would not be. But that's just an example of the fear that's out there when there's lack of knowledge and confusion on a policy like this, which would multiply strongly, significantly, if this were expanded to all foreign assistance. There was significant mission level disconnect where the US government at the DC level They were trying to understand what the policy meant, because again, it's sort of like flying a plane as it's being built. No one really knew what it meant. It was just thrown out there, and it's like, go implement it and figure it out. And the people at the mission level in the field knew even less. So for example, one time they tried to apply it to a water and sanitation project that was not subject to the global gag rule. And we had to work with USAID at the DC level to talk to them, get them to agree that this was an overly broad interpretation of the policy. And then the local mission level then amended the grant so that it did not say it was subject to the global gag rule. Another issue came up when there was a grant with a small bucket of money that was family planning funding, but nothing else had anything to do with global health. So the question was, did it contaminate the entire grant? Or is it just that particular activity that was being implemented? And the answer was, it was just that particular activity that was being implemented. It did not contaminate the entire grant. But that ability to talk to USAID lawyers in DC and get feedback from our field in terms of how it was being implemented, that communication was a critical part of really trying to ensure that we mitigated the harm of the global gag rule. So that close communications between field staff and between the headquarters is extremely important. So what did we do to try to mitigate the harm and to ensure compliance at the same time? Well, I think one of the most effective resources that we created was a compliance working group that was focused on legal interpretation and compliance procedures with the objective of ensuring that permissible activities could go forward and ensuring that we did not have overly burdensome compliance procedures and overly interpretive legal interpretations that would add to the chilling effect. We want to make sure as much as could happen at the field level could happen. So we essentially created a platform for implementing partners so they could ask questions, exchange information, exchange materials, share what we're thinking were, and strategize on legal and compliance-oriented questions to ensure that there was some continuity and rationality behind what was being done. And also to minimize duplication of efforts. As others have spoken about, the administrative burden is extremely high on NGOs dealing with how do you comply with this? How do you make sure that burden is significant? So if we can work together as a group and minimize some of the duplication of effort, that's a big win for everybody. That just helps us all. And we were able to engage, as I said previously, with USAID local staff and be able to get information from them and share our concerns with them, mostly at the DC level, in order to make sure that the effects of the global gag rule were not overly broad. Training was another critical component to ensure compliance, but also to ensure that people understood clearly what could or could not be done and to reduce that chilling effect. And in completing the training, it's important to consider who's my audience. So this is you have to train the headquarters staff, you have to train the field staff, you have to train the NGOs, the local foreign NGOs that you're working with. The training has to be significant and detailed, and it's a lot to take in. So we also created written guidance, and we also created FAQs, frequently asked questions, and had them all translated into appropriate languages so we could broaden the reach of that information. But still, there were significant questions. So it really does require someone in the compliance and the legal area working very closely together and open communication so that we could know what was going on and try to address issues as they arose. We also created a partner assessment tool because, of course, due diligence is extremely important to ensure that the local NGO is complying. And in doing that, we created a questionnaire where our field staff would sit down with a local NGO and go through all the activities that were prohibited, see what they were doing, make sure they understand what the restrictions were so that they would not participate in any of the prohibited activities during the term of the grant. And that's one thing to keep in mind. Only during the term of the grant do the restrictions apply. Once the grant's over, an organization, if they're not taking further US government money, can go back to what they were doing previously. So that due diligence was a key part of it. One thing that every organization has to consider, and this is sort of a threshold question, is, do I want to take this money? That's going to be a question that each individual organization has to answer based on its missions, its objectives, and its strategy in terms of what it wants to accomplish. some things to consider. If you don't accept the money, will there be a vacuum in the field somewhere? Will that vacuum be filled by an organization who is not worried about the chilling effect, who has very different values and objectives than what you might have? And if you leave that vacuum in the field and it's filled by them, what will be the effect on the community? Because after all, that's the biggest effect. It's on the women and girls and the families in the communities. It's at the community level where the harms are really being felt. And so, and also, if you don't take the money when the global gag rule is rescinded with the next Democratic president, will you have a void in your, will you not have enough staff? Will you have lost your expertise? Would you have lost the local partners that you had reliance on, that you worked with closely? And how will you get that back? So CARE has made the decision in the past to continue accepting the money subject to the compliance. So we didn't want to go in and out of different fields, particularly when the expansion with the Trump administration. We felt like it was very important to stay involved in the global health field. But that's an issue that everybody has to answer for themselves. Also, having a seat at the table to be able to talk to US government lawyers, to be able to try to influence interpretation, to influence how you comply, I think is a really critical part, to be seen as a trusted partner who can talk openly with the US government. And a lot of the large INGOs in the United States can do that. So that's a valuable aspect to keeping with the money. I want to address a couple things maybe one thing that Jen talked about. If this is applied to US NGOs, it's likely going to be, well, it will be challenged in the courts because there's a First Amendment right that US NGOs have that does not apply to foreign NGOs. And there's strong precedent for that First Amendment right being valued at the Supreme Court level, the US Supreme Court level. But what would happen, we don't know. I just know that would be fought. The expansion to the broader funding would be a tougher legal challenge to bring, but it's under consideration. That's really about all that I have to say, but I'm sure there are a lot of questions that you all have for all of us, and we're looking forward to answering those. So thank you.
Thank you so much, Jane. That was great and daunting at the same time. So yes, I see we're getting quite a few questions, but we first want to hear from Ibrahim. Ibrahim, I know you're having a little bit of technical difficulty and delay, so we will do our best to work with that. But I'm going to turn it over to you to speak on a local experience.
Thank you. Maybe I can switch off my video to have a more stable connection, and then I'll switch it on back.
Okay.
Yeah. So thank you so much for the opportunity to speak during this interesting webinar, especially talking about the implications of the policy on Uganda and Africa. So one, I'd like to note that
Ibrahim, we lost your audio. Oh. Ibrahim, can you hear us? Okay. Maybe we'll take a couple of questions while we're waiting for Ibrahim to adjust the technical issues. Sorry about that. So let me just start. There are a lot of questions in the chat and in the Q&A. I'm going to try and, are you back? No, Ibrahim, we can't hear you. Sorry about this. Sorry about the technical difficulties. Ibrahim, maybe if you sign off and come back on. In the meantime, Jen, perhaps you could answer one of the questions that was in the chat. Chris Collins asked about multilaterals. I think this has been a concern for many of us thinking about the expansion, that it could not only impact bilateral health and development assistance from the US, but would also potentially expand to impact things like the Global Fund or Gavi or US contributions to WHO. Can you talk a little bit about that piece and what you've found so far?
Sure. Yeah, it's a great question. So we haven't done a legal analysis, but from looking at the policy proposal and looking at what is already known about US law and then the purview of the executive, I think there's some gray area, and where there's a little bit of gray area here is when it's assessed contributions, let's say to a UN organization, whether it's WHO or any other UN body. I think there's some gray areas to whether any kind of policy condition could be applied to assessed contributions that are really like membership dues. But for voluntary support, which most US funding to multilaterals is voluntary in the sense that it's the US government, Congress, and agencies partnering with an international, a multilateral organization for various projects or general support, that as far as I could tell is very much within the purview of the executive branch. Now, whether that could be legally challenged or challenged in terms of if there's some role that Congress has there that would come in conflict with the executive branch is a question. But I think the short answer is it looks pretty much like the executive branch would have authority to apply to many of the multilateral contributions.
Okay, thank you. And I think, Ibrahim, are you back with us? Do you want to try again? You're on mute right now. No, you're still on mute. Ibrahim, we cannot hear you because you're muted. Okay, up there, Ibrahim, can you come back on? No. Okay, we're still having trouble hearing you, Ibrahim, so I am going to take another question. And this one is in the Q&A. Someone asks, how can organizations that do not take a stance on the Mexico City policy help mitigate the impacts of the policy? How can we come alongside other organizations and be helpful? Who wants to take that one? There's a couple of questions about solidarity and forging a broader community. I think this one is part of those same set of questions. So I'm just going to add in another one asking about whether the prior expansion from MCP to PLIGA created perhaps a larger coalition of solidarity partners around family planning and SRHR or other related sectors. And just, heeding Jane's recommendations on sort of how you make the decision of do you take the money, not take the money. There was another question about whether we have data on what that implication is. If there are groups that didn't take the money, did that impact things in a different way than for groups that did take the money? So I don't know who wants to start on those. It's pretty big ethical questions right there, but this is of course a big ethical issue. So maybe I could ask Caitlin to start and then turn to Jane.
Sure, happy to. Thanks for the good questions. I do think the expansion of the policy from family planning funds to all of global health did bring new organizations and stakeholders into conversations about the policy and advocacy about how we mitigate and potentially ultimately end the policy, which I think was welcome. I think for those of us who have been battling the policy for all the years, it would have been good to have that solidarity earlier so that we could have nipped it in the bud in a different way. But of course, we welcome any new partners coming to the table to lend voice on what the policy does and why it undermines our global health efforts. So I think we saw this play out at coalition tables where all of a sudden it wasn't just the reproductive health tables that we're talking about this, it was HIV tables, it was maternal health tables, and that was really welcome. We also saw it as a big point of conversation in spaces like the International AIDS Conference, so major global convenings where stakeholders were coming together. And I think that was helpful to broaden the conversation and ultimately reach policymakers and media who, have influence and really show where we're in this together and the broad impacts of the policy. I'll turn to Jane on the question of complying or not, but just to say, I think these are impossible questions for organizations. We're asking people to either give up huge swaths of funding that is critically needed at the community level, or to give up their ability to offer comprehensive services and speak about what their community needs. That is not an easy choice. And I think people who make both decisions suffer under the policy. So appreciated the question about, for those that maybe don't take a stance on the policy, what can you do? I'd say try to remain in partnership, but don't pull away from organizations based on what they decide. I do think remaining in dialogue together is really key. And we don't want to reinforce this binary of complying organizations or not. I think everyone has a role to play and everyone suffers under the policy, but welcome comments from my other panelists.
Thanks so much, Caitlin. Jane, I'm going to ask you to just hold for a second because Ibrahim is back with a stable connection. So I want to give Ibrahim a chance to be heard. So Ibrahim, over to you.
Thank you so much. I'm so sorry about the connections. I'm outside Kampala and I'm struggling with the connection, but I'm glad that I was able to connect. One, I would like to note that, one, we thank you for giving us the opportunity to be able to share our experience of the implications of the policy in Africa and Uganda in particular. One, we note that the policy is a manifestation of neocolonialism in Africa, where the US government continues to influence and control how we deliver health service provision in Africa. In that regard, we think that the implementation of this policy continues to intrude the sovereignty of African countries to determine their health priorities and SRHR interventions. In our view, we think that we need to think about designing contextual approaches that are geared towards decolonizing aid in Africa. We'd see that whatever aid we receive in Africa has no restrictions as presented in the Mexico City policy. It is equally important to note that the US government has an international cooperation obligation to see that they extend technical and financial assistance to developing economies such as Uganda. But however, most of our countries are unbothered about the policy, given that they don't see it as a direct effect on their budgets. Yet, majority of our funding for the health sector is from foreign assistance. So the effect of the policy on our health sector system is unmeasurable. And interestingly, or unfortunately, the policy is being applied in already a struggling health system, which compounds the suffering to the vulnerable that use the health system for a series of health services. And interesting also to note is that we are operating under a colonial legal system where a number of SRHR services are outlawed, some are restricted. And with the policy in place, we see that we have a continuous inhibition of access to critical SRHR services. So the overarching effect of the policy even entrenches this direct service delivery down in the facilities in our grassroots communities. And majority of our Ugandans can't even afford to be able to access care. And the little resources that have been drawn through foreign aid, then they are curtailed because of the policy. And some of them have also found themselves before the justice systems where they are arrested and even charged for accessing services like abortion, yet they're also struggling with the financial aspect where they can't even access the services. So they end up going into unsafe methods, and we see a number of mortalities and morbidities happening because of the policy. So the policy directly affects vulnerable Ugandans, and we need to see that our government should pick up this, because majority of the funding that we receive in the health sector through private actors. So for instance, if the funding to institutions like Maori Soaps International, PSI, and the rest are tremendously cut, the effect goes to the communities that access these services at a favorable or even free care. So we need to see that we have a comprehensive voice that pushes back on the negative impacts of the policy on our healthcare system. Also note that while we think that as Africa, the policy affects us, we don't see African institutions like the African Union, the African Commission come up or have approaches that can shield the continent against unfavorable foreign policies. It is the same case with our regional economic communities like the ECOWAS, the East African Community, SADC. They don't see this as something that would affect them the way they look at the political aspects, the trade issues, and the economic issues. So we believe that if we would enhance capacities of African organizations to be able to engage the African institutions or even the RECs at that level, to see that they have targeted interventions that can be able to push back against policies, because we believe that the effect of the policies goes beyond the parameters that we see in the policy, but it affects even services which are core and critical to our citizens, like maternal health. So we think that it's important for us as CSOs to be trained. We have at Afya na Haki, we have organized a series of customers trainings to see that we empower CSOs in Africa to be able to have the knowledge about the policy, but also to see that they can be able to push back against adverse effects through engaging the governments, but also through engaging the African institutions, such that we have a unified voice as Africa against the policy. I would like to note that while CSOs, of course, the role is relegated to CSOs to be able to push back, we operate in a purely shrinking civic space, which also complicates the advocacy and the pushback interventions that we have usually come up with, to see that we, at least we push back on the negative effects of the policy. So it becomes complicated in that perspective, where CSO is supposed to push back or even to support the affected communities. They are also gagged. They can't even speak through a system. Even they're operating within already a colonial legal system that restricts or even outlaws some SRHR services. So we're operating in a complicated environment. While some people might argue that it's only health which is affected, even legal aid service provision was affected, where, for instance, women that would suffer gender-based violence, that would benefit from the treatment and the legal aid services, they could not access the services because the funds were gapped. And the majority of these are in hard-to-reach areas. So the impact is unmeasurable. We also witnessed that a number of health workers were supported by the projects lost their employment. And we're already struggling with the meager resources that have been invested in human resources in the health sector, for instance, in Uganda and Africa generally. So you see that if the few health workers that we had that were supported by the projects are lost because of the policy, again, it is the civilians, the grassroots people that suffer the adverse consequences of the policy. Yet, these services that are gagged are part of our minimum healthcare packages that we have in Uganda and other countries in Africa. So we believe that it is important for us to join our efforts as CSOs, as even the public sector, to see that we try to come up with mitigation measures of how we could curtail the adverse effects of the Mexico City policy. And again, it draws back as governments. How do we strategically start to think about how we fund our health sector as Africa? How do we support our health sector amidst the challenges that we see that come directly through the foreign aid policies that are enforced by the developed economies? So we need to see that we have targeted trainings for groups that are doing advocacy on this issue. We have groups for litigants. I've read about a number of cases that have been instituted in the US. They have all failed not because they're not raising legitimate issues, but there's a question of, are you affected by the policy? So we need to train and empower lawyers, for instance, to be able to prepare litigation cases that can be able to provide justice to the women, the girls that suffer because of the Mexico City policy. The advocacy groups, we need to prepare them to be able to engage at the level of the Senate, to engage at the level of the African Commission on these issues. A fraction of African organizations can able to speak about these issues. And I think lastly from my end, we need to see that we also invest in African-based research. What are those narratives that we need to tackle as Africa on the Mexico City policy? Or we have to rely on research that have been done by our counterparts in the West. So we need to see that we think about also having a research agenda that is Africa-based, to see that we design interventions that are informing advocacy, informing litigation, informing communication, that can directly be informed by our African environment. And I think lastly, from my side, is that we need to see that we work together as a bloc. Our governments should wake up and know that while they are not affected directly, the impact is on the citizens. We need to see the public and private sectors in our countries in Africa joining forces to push back on the policy. That's what I can say for now. Thank you so much.
Thank you, Ibrahim. That was a really powerful example of like how detrimental this policy is and who really gets hurt by it. So I appreciate you bringing all of those pieces to the front. I am wondering, while you're here, spotlighted, there was a question earlier in the chat about countries who receive US funding where in that country abortion is legal. Are you, in your conversations with other partners, are you talking at all about that component of it? That there are many countries where abortion, whether it's for exceptions, for maternal health or rape or incest, abortion is legal in country, and this kind of policy goes against national law. I'm just curious what the conversations are from your side, and then we can turn to some of the other panelists as well, because I know this has come up in the US before. But please go ahead.
Yes, it is true. Our legal environment on abortion is restrictive. We have a few exceptions, especially where the life of the mother is at risk. But in the interpretation of the Mexico City policy in our context, our governments and our in-country US-based partners, they don't look at the policy as only abortion. The policy has overarching effects even to family planning, to immunization, to HIV, and other health sector services. So I think beyond the legal frameworks, we see that our governments are relaxed. They don't mind about the policy because they can receive funding from the US, but the civil society organizations, the service providers are supporting the communities that do outreach services, the communities that bring services to the communities, they are affected. But also our funding in the health sector, like I said earlier, is majorly through foreign aid. So the impact is felt. And when you speak to technical people in the ministries, they feel the pain. They think when a policy finds an environment like our country where there's a restrictive environment, then the impact has a big or a massive effect, because the policies is coming within already a compromised system, which is colonial, which is based on laws that were shifted to us. And then we see another policy being shifted to us and we continue to suffer. So it's a compounding effect where you have a colonial policy, a foreign policy from a developed partner who is trying to see that you don't have access to services because of the policy. Because I can't claim that our country is ready to support the services. We need aid, we need support. But how do we decolonize the aid? How do we determine our priorities as Africa? How do we determine our priorities? Even amidst our challenging laws. Of course, from our end, as African Hack, we are trying to push on the laws. We are trying to file cases. We filed cases, litigated cases on maternal health, litigated cases on abortion, on sexuality education. But But we need aid, we need support from those governments. But how do we ensure that the governments release resources without restrictions, such that we fight on our front of challenging these laws, and then our people can be able to access services? But when you have an environment where you are in court, but the aid is gagged, the support is gagged. But also it is a call to our governments to start thinking about how they can finance the health sector. We talk about health insurance, for instance. The government is not prioritizing this. So our people are suffering because we are relying on foreign aid for support. Of course, we will do the colonial campaigns. How do we decolonize aid and what? But our governments have to wake up. This is a wake-up call to our governments. They have to invest in the health sector. Otherwise, we are going to see a scenario where we have 0% of funding and people are going to die without any support. That's society. We'll be handcuffed. We don't have anything we can possibly do to support our people. So we need to look at this issue in a holistic way, beyond the effects, but how do our governments prioritize funding of the health sector?
Thank you. That was terrific, although not maybe what we all wanted to hear. There was a lot of struggle there. Hopefully we'll get there, but thank you for that. I want to turn back to Jane because I interrupted you from answering another question earlier, and there were quite a few questions about compliance issues in the chat and in the Q&A. So one was the earlier one around solidarity. There was another around how do you implement this around humanitarian funding, which is often for an acute crisis. What's the due diligence piece that needs to happen? There was another question about whether there had been any kind of prosecutions of non-compliance. What's the probability of that happening? And then if you could quickly answer those, I'd like to just go back to Jen, to Jen Cates, because there's a couple of questions in the chat around multilaterals again, and sort of the types of institutions where this would be applied and what that looks like. Another question around whether it would also be applied to organizations like the International Federation of Red Cross. We'll try and answer these. We only have just if we're at time, actually. So if Jane and Jen, you could give sort of 2-minute answers. And what we will do is when we send follow-up information, we'll also try and provide some additional answers in writing. So let me go to Jane first, and then Jen, if you can just hang on for 1 second.
Thanks. Great questions. Can't do much justice to them in a short time frame. However, I think advocacy is the most important step for those organizations that are not taking a position per se, whether they take the money or not, but working in solidarity, as Caitlin said. It doesn't matter whether you decide to take the money or not take the money. We are all in this together. We all have a common mission of helping the communities where we serve. And so how we go about doing that when our values are the same is what's important. We have too much division in this country right now. We don't need this among the INGO community. So we need to work in solidarity. In terms of prosecutions, I'm not aware of any prosecutions of anybody that lost their grant, but I don't necessarily have the lens for that. I know that didn't happen with CARE, and I never looked more broadly at it. So I can't, maybe Jen can speak to that. I'm not sure. In terms of lawsuits, someone asked a question, is there be expensive to fund a lawsuit? We have brilliant pro bono lawyers who are supporting us in this. So if a lawsuit were filed, it would be done by pro bono law firms, and it would be done, it's a matter of who's the right plaintiff to bring this. There's a lot of strategy about that if that happens. The due diligence in the humanitarian sector, that's a really tough question because that does have to happen quickly. I think you probably have to take a little bit more risk in that environment. Maybe you do your due diligence as best as you can, as quickly as you can, but it won't be able to be as thorough as when you're in a development stance. And it's really a matter of the risk profile of an organization balanced against the mission and how you go about accomplishing that. Not a great clear answer because we've not had to deal with this before, but it's a great question. I'll be quiet and go back to Jen now.
I'll be very quick. We're out of time and people are dropping off, but very quickly, the penalty that has been in place in the past when the policy's been operating is you have to lose your funding. So prosecution, I'm not aware of prosecutions. It's really about you have broken the policy, so you can't get U.S. funding, and there's a provision to repay the U.S. government in some cases. So that's really what people have to be aware of. On the questions of multilaterals, the proposal that has been put out there would apply to public international organizations. So yes, the National Red Crescent, basically any international multilateral, even public international organizations which have been designated as such by the US government would be newly subject to it under this proposal. Thanks.
Thank you. And I know there's so much more to say here. This was such a rich discussion. We have recorded the session. We will send the recording as a follow-up along with some additional materials. We'll take a look back in the chat and the Q&A, and if there's anything that we completely missed, we will send some additional comments alongside that. Thank you so much, Ibrahim, Caitlin, Jen, and Jane. So appreciative of your insight and expertise. And thank you all for the wonderful questions, and have a great rest of the day. Bye, everybody.
Bye. Thank you.